What's up? What's up? Welcome back to the podcast. Welcome back to Theory and Theology. On this podcast, we talk about different theories, cultures, religious topics, and all sorts of things. Today, I'm kind of wanting to talk about a psychological theory. One of my favorite ones. I had a clinical supervisor who was the most, I guess you would call it, kind of hands-on class type of supervisor. And we talked a lot about John Fredrickson's ISTDP. And so I'll say that again, ISTDP, intensive short-term dynamic psychotherapy. That's one of my favorite kind of methods. Let's see. So, oh my gosh, I'm like yawning and everything today, guys. I'm tired. A little tired. I'm a little tired, yeah. Not like super tired, but I'm a little tired. But yeah, at work, a lot of people know, I don't really do a lot of direct therapy anymore. And maybe that's why I've been kind of like not so into this job, because today, yesterday, the day before, I've been working with a client on a situation that, kind of feels more up my alley. It's kind of more my vibe of how I prefer to work. And, it's nice to be able to provide value in that way. And I don't know what people really think. I mean, I'll get more into talking about boundaries, so I don't get like way off topic with this, but yeah, we this client and myself, have been working together since like, I don't even know how long, like absolute ages. Oh yeah, that's right. So like since spring of 2021, but I think they were one of the first people I enrolled. I feel like they were enrolled sometime near like June or July of 2020. I can't recall, but basically it's one of my younger people that I work with, and this person pretty much went through a lot of stages of getting out of multiple abusive, dynamics, through a combination of, housemates, roommates, family members, and I mean, the common theme that I usually see, and this is likely just the population I work with too, because everyone we work with has a certain limited income, and everyone we work with has a certain limited, I don't really want to say a limited educational background, but more so like a limited ability to be able to work full time. Usually it's due to symptoms, but sometimes other things, like health complications, not necessarily mental health complications, but physical health complications, or, in this case, the person is, on the younger end, so they're not very established in their career, so they do work and they are able to work. They probably work more than 40 hours. Like, it's kind of hard to really get all the details, but they have multiple jobs, you know, but you know, they're not getting paid like too much, like 15 or so an hour, and that's like before taxes in Southern California. So it's like they're not getting like a very high livable wage because they're, you know, they just got out of school not that long ago, and they're not, you know, they don't fully have their degree yet. They're still kind of wrapping up some loose ends with coursework, and you know, having to pay off a bill. You know how it is, like you can't get your transcript or your degree posted until you finish like every single thing. So they've got a couple last steps, so they're having to deal with that as well as work. Did a super fantastic job of engaging themselves in services. They definitely advocate for themselves. They definitely ask for help when they need it. They're not like pushy, but I notice like they have a very I'm not really used to working with people who are so like proactively engaged in their own recovery process and process of you know, engaging with support. Like usually I feel like, you know, we work with an older crowd, and usually they're kind of like, I don't want to say set in their ways, but like they usually maybe don't need as much from us, or like feel maybe weird asking us, especially because like, you know, this type of field that I work in attracts kind of a younger crowd of people who work, you know, like we tend to not really all have, you know, like older age, like families, you know, like some of us do, but like a lot of us are in like our 30s, a couple people in their 20s, a couple people in their 40s. A lot of us are pretty much in our 30s and have roommates or are, you know, dating but like not married, and so we have a lot more energy, and we're early in this phase of our career. So I guess what I'm trying to say is like, you know, it attracts a certain age range of people who are still early in their career, but also quite established, know the resources. But a lot of us are kind of seeing if we're phasing in or out, have been working in the field for a long time. Like most of the people I work with aren't new. Like there are a couple who are like brand new and still like working on getting masters and stuff like that. But most of the people I know have had a master's degree for at least like almost 10 years, 6 years, 5 years, have been working in very intensive case management and therapy and crisis management sites and hospital sites. Like, you know, we're used to like a more intensive population. The population we work with is in need of intensive support, but they're also very connected with so many other programs. So we don't really take the most intensive role anymore. We don't do the intensive case management. We don't do a lot of the crisis management. We do kind of like the mop up and the intervening when things kind of aren't working out. So it's kind of a weird role that I have now, because it's like they call us when they need something, but then we kind of need them to engage sometimes more than they call us. So it's kind of like this push and pull of like, okay, like, can we help you? We need to call you at least every month a couple times. And then they're like, nah, I'm good. You know, like if they don't have an appointment, but like once every 3 months or something, they don't really need to talk to us every other week. So it's like, you know, they have therapists, they have case managers. They like oftentimes, like if they don't, when they first enroll, we get them connected to every single thing. So, so we basically are able to be like talking, you know, we're able to be like talking to our clients pretty much how do I say this? We're able to talk to our clients kind of more so when they need us to engage with them, which kind of makes the role a little less ideal, because it's like you're not following up so often, and then things come up, and then you're like, oh shoot, now I gotta like backtrack and like figure out what's been going on for the last couple weeks up until this point. Like, we're not like involved with them weekly. We don't have a whole team of different providers that's like in the same exact office physical space as us. Like, we have to track down their other providers, and then they have to be willing to coordinate with us and give us that information. And sometimes, you know, if our clients don't want us to contact certain providers, like, they just don't tell us who they're working with. And we don't usually have access to like all of that. Like, it takes a lot of digging to be like, who's this person seeing? Like, who's their psychiatrist? Who's their nurse? Who's their therapist? Who's their cardiologist? Who's their physical therapist? Who's, you know, I have clients who see certain providers that I never even knew they were like seeing those providers, and then all of a sudden it's like, oh, you need to follow up with this person, and I'm like, I don't even know who they are. I don't know their name. I don't know what site they work for. So that gets to be a little like, it's like not efficient. There's a lot of little like inefficient things that it's like, you know, a lot of our you know, clients kind of like withhold information from us because we're such a casual type of a site. It's like, if they don't want us talking to their, you know, drug counselor or something, they just don't have to tell us that they're, you know, relapsing on substances or anything like that. Like, they don't have to tell us certain things, and so we only kind of know what we're told. And so a lot of times we're like finding out new information all the time. But with this person, it hasn't been like that. They've been very engaged, you know. They like to have weekly contact, even if nothing's really going, you know, south and things are going well. They like to just report back and talk almost every day. Like, we kind of like, you know, go back and forth almost every day, at least every week. And so it actually helps to have a lot more, you know, collateral, a lot more details about this person's situation. So when it comes to helping them, you know, with boundaries and things like that, it's been really nice, because, like, you know, I've known the whole situation from the time that they graduated from school to when they had to move and then had to do all these different things. Like, we know like the whole situation from when they started needing our support and all the steps of the way, what's been working, what hasn't been working, what kind of stuff is coming up here and there. So anyways, that kind of got me into this, back into this, you know, conversation about ISTDP. And I know I've talked about it on here before, I'm pretty sure, but it was probably like a year ago or more. But like, the reason why I like it is because it's a very collaborative therapy. One thing I noticed, and this is for people who maybe haven't had a lot of therapy, or a lot of like services in therapy, or a lot of education around like how to get therapy, how to get life coaching, how to get different types of stuff like that. When I learned this approach, I feel like it helped me the most, because the clients felt the most heard. Now, it's not the only approach that's ever going to work, but I think it's a good approach to take, to pop in and out of, with different with different situations that come up. Because, you know, there's this question that Friedrichsen kind of goes through when, you know, you're going through these kind of like scripts, I guess you would call it a script. It's like, there's always a scenario, there's always like a case study, or some kind of I forgot what you call it, when it's like they give you like this like kind of rundown of the person's presenting problem, and then you just kind of kind of start talking about like what method you would use, to kind of, address treatment and interventions. And so I like the strategic method of it, how it starts with, well, not necessarily always, but like it kind of starts with the idea of, what is the emotional problem that you would like to work on now, today, in this session. And the reason why I find that important is because a lot of times clients come in and they want to work on something, but maybe they don't articulate it, or maybe we just beat around the bush and never get there. Another common thing that happens is, the session's supposed to be limited to 45 to 50 minutes, and then, they might bring up the main emotional issue that they want to be working on, 5 minutes before the session ends, or right when the session ends and you're scheduling, and then they're like, oh, by the way, I've been having like severe anxiety and losing sleep over all this stuff, and like, so that kind of situation, is like this approach kind of helps to guide kind of where the sessions go, and asking the person, what's the emotional problem you want to work on today. It's like you're actually working on emotional issues, right? Because a lot of times that's what the clients mostly want to avoid, is the emotional issues going on. And so it's possible to work with a client for years and never work on an emotional issue. It can be always just like, okay, let's, like, not directly working on their emotions. It can easily be like, come in, talk about, the layout of my week, everything that stressed me out, and I'm gonna vent or talk about these things, and I don't really actively do any work on any of these underlying emotional issues ever. That's kind of comfortable for a lot of people, and it's comfortable for a lot of clinicians, but you're kind of not really talking about anything, on the emotional level. And the thing is with psychology is a lot of times there are other fields that we kind of dip into and have to kind of be knowledgeable about to try to like help those folks. And so it would almost be like if you went to a doctor because, you had some severe hyperextended knee issue or something. Like I had a really bad hyperextension, with one of my knees, like back, like the first year of my grad school when I was playing soccer. And that, didn't go away for like years, probably almost. Like it felt like it was at least a couple years. I was limping around for at least like almost like a month or something. And, I wasn't even talking to a doctor. Honestly, I never even thought to like talk to a doctor because I was like, it's not broken, like whatever. But definitely the pain was there. It would get cold sometimes, and if I was in AC or if it was like raining, my knee would just be like a little bit of throbbing pain, or like, I couldn't really actively play sports for like quite some months. Like it was pretty tender, pretty sore. I had some limitations with it, and but if I would have gone into a doctor and they would have just been talking to me about my emotions, it's like, okay, like how's this gonna fix my knee? How's this gonna show that every time I come in to the next session or follow-up that my knee pain or mobility issues are improving at all? Like we're not even looking at the knee mobility problems. We're not even looking at the pain issues of the physical pain of the knee. We're talking about my emotions throughout the week. That's and that's like I say that to talk about like with psychology. It's like that's kind of the approach that not all psychologists take this approach, but a lot of times it's easy for a client to kind of force their preference or comfort level into the session because they can easily just deflect and avoid and use these kind of defenses to just easily just be like not even on purpose. This is all like kind of like not even fully conscious behavior, like we all do it in our daily lives, Imagine the last time you talked to somebody that asked you a question you didn't want to answer. I mean, as humans, we're really skilled with like social, like usually we're very skilled with like socially expressing and withholding, what we want to say or what we don't want to say. And it's totally fine. But if you're coming to a provider to help you with something, usually the therapist is there to help you with the emotional aspect of things, the support aspect of things, and what easily can happen is a client coming in routinely, never talking about the emotional issues or never really talking about them or working on them or wanting to work on them or getting comfortable with working on them. And then the cycles just continue. And they don't really, they might learn a lot about it. They might see a lot of things. But if they're not working directly on the emotional issue, it gets really challenging to kind of, feel like things are moving forward with their emotional conditions. It's very common with people with borderline personality disorder and other types of personality disorders, just because of the kind of like the social distortions involved. I guess like the distortions involved with like how they kind of view the situation. Like, do they feel like they're always the victim and they never notice their role and how they're impacting other people, or how their emotional state leads them to do or say certain things in social settings, and then other people just kind of don't really vibe with them. They present the story very one-sidedly. They usually can't see the other person's perspective, or if they do, they really couldn't care less, depending on what type of personality disorder it is, so it's kind of harder to work with people like that. And depression can be hard to work with because the motivation to even engage in therapy and just like the level of being able to process things, if people have poor memory issues or just like trouble even getting out of bed to come to an appointment or engaging in appointments or following through with any kind of homework. Anxiety can be hard because it's hard for people to focus, like every type of emotional condition has other issues that make it hard to kind of work on the emotional condition. It always leads to a certain type of defenses that make it so that the person isn't actively always working on that emotional issue. So the thing I like about ISTDP is that question, what's the emotional issue you'd like to work on today? And sometimes, they just want to check in about their week and all that kind of stuff. And, you don't want to be too pushy. There's always like a line. It's like you don't want to be just like pushing your own agenda all the time on the clients. But usually what ends up happening is that because of the dynamic that kind of goes on in therapy sessions of this like avoidance of the emotions and then the defense mechanisms just kind of naturally automatically coming up, and then the therapist might not catch it right away, and then the story veers off into some other direction of them like venting about something that their great grandfather's uncle did to their cat or something when they were like 4 years old. It's like, okay, like, is that really what you want to work on today, or are you just remembering this and you don't really want to work on it? It's like it helps to choose one thing to work on. Yes, let's catch up. Yes, let's talk about your backstory. Yes, let's talk about what's on your mind. Yes, let's talk about, what's coming up in your future and all that kind of stuff. But, eventually the emotional issue needs to come up of why it is that they're even coming into therapy in the first place. And that needs to kind of routinely be worked on. It's really hard to get to that place because a lot of therapy models don't really have you actively addressing that. And if you're working with populations of people like the ones I've worked with, the ones who, need food, need shelter, need rides, places, like they're barely able to like get by as it is, it's really hard to start working on emotional issues when you don't have your basic needs met. And then we do tend to be taught in school oftentimes about here's this freaking, what do you call it? Here's this here's a thing for you, like a worksheet, or we can watch this video and discuss it or whatever. But a lot of times if the client doesn't have the buy-in, like if it's not really what they want to work on, they're not going to work on it. So there's this disconnect a lot of times of being like, this client isn't engaged, they're not motivated towards treatment. And it's like, a lot of times it's like, well, the therapist might not be working with them on what they prefer to be working on or what they're ready to work on. And so you can give them all the worksheets they want. You can give them all the educational resources you want. And then the client will not even do it. Sometimes they'll leave it in the office or in the group therapy room. Sometimes they'll throw them away or leave them in the lobby. It's like, sometimes they don't even take it with them. So it's like, well, clearly they didn't want this, And so, I'm not saying that in an offended way. I'm just saying that's kind of how we all operate. If you went into your doctor for your hyperextended knee and they started giving you therapy worksheets or something that's completely off of what you're trying to get help for, and you look at it and you're like, I didn't even come here for this, you probably wouldn't keep going. Or, if you did keep going, you wouldn't really feel like there was a good rapport or that your doctor heard you or anything. But with therapy, it's a little different because a lot of times there can be this kind of dancing around like work that's not really work being done, and I think also because of the lack of exposure to mental health services up until 2020, most people never even were the mainstream society was never even talking about mental health. And when they were, it was through Hollywood, and we all know how that goes. The Hollywood picture of anybody's situation is not fully accurate, and that was kind of the only exposure mainstream, at least Western Americans, were getting about therapy and mental health. And I have some close friends from Cambodia, and they've all told me that the system there is even way different than in the US. That in Cambodia they have psychiatric hospitals for the most severe situations, but something mainstream therapy and that kind of thing, it isn't like it is here. It's still kind of taboo. It's not really something that people really are gonna actively be trying to be proud to go and engage in. They have other systems for handling emotional issues, other spiritual systems, other family systems. And I'm not saying there's anything wrong with that. It's just culturally, most cultures don't really have a view of psychology. And if you do, it's this weird kind of view of I would never go into therapy because that means something about me that's negative. Even as somebody who works in therapy, who talks to friends, we all, not all of us, but a lot of myself and friends have engaged in therapy sessions for our own mental health, just to even cope with work or to cope with whatever the heck is going on in our lives. And a lot of us are even I don't even know if I should say that, because it can be awkward. It's do you tell your therapist friends that you're seeing a therapist? It's that can be awkward. And so I can even imagine how it is for other people who didn't go through years and years of school training to be into therapy like that. So yeah, I feel like I do like the ISTDP model because of how they engage with the client, doing collaboratively working on an emotional issue that they're ready to work on at the level they're ready to work on it with. But also just it takes so much energy from the therapist to be so in tune with the defenses that come up, to kind of switch the subject or it's simple, subtle stuff, like, you can ask a client about, like, what's the emotional issue you want to work on today, and they might be very skilled with their communication with that and know how to answer the question and be like, okay, like, I want to work on this emotion of the anger that I'm experiencing because of the court making me have to interact with somebody during a restraining order process when I've been trying so hard to set boundaries with this person to get them out of my life, and that's, it's valid, it's like, okay, you're angry, let's work on this anger. And then you ask them to kind of talk about the anger, and then they might get into the story and get more into the backstory, and there's definitely going to be some trauma themes there, and they might go way back to, like, I remember when I was this age and this person was yelling at me and manipulating me and doing all these things. And then as a therapist, it's like, okay, well, you have to listen to them. You can't just be like, wait, we are no longer talking about your anger, you're now talking about your childhood memory and this whole story. It's like, let's get back to the anger, and that kind of stuff happens so subtly, and then it can be difficult for a therapist to be like interjecting and being like, yo, did you notice, because what you're supposed to do is you're supposed to kind of bring up the defense that's coming up and actively be like, did you notice how, when you started talking about your anger, you kind of went a little bit off track and started talking over here about this other thing, and we're no longer talking about anger anymore. Yes, it's related, but we're now talking about some other story. So things like that, it's like, it's very subtle, and it can be very abrupt, like, to try to approach it. I mean, that goes against my natural, social, ways of interacting with people. Like, I'm not really one to really be like calling people out on stuff. Like, that's like awkward to be like, yo, did you notice that you did this thing? And like, it just feels like weird. Like, you're not doing it even like from an ego trip kind of way. You're just kind of pointing it out for their own benefit so that they can see the pattern that they go through when they say, I'm ready to work on this anger that I'm experiencing every day, but how the defenses take them away from working on the anger. Like, the more you point it out, the more they realize, I'm not working on this anger. I'm thinking about the backstory. I'm stuck in this cycle of ruminating thoughts about this area. And just kind of like people feeling like they're under a microscope almost, like, or feeling like invalidated. It's easy for someone to feel invalidated when they're sharing about, a trauma story and about their lives and about their past. And then it's like, oh, I'm sharing about my past trauma, and then you're like interrupting me to take me back to this thing. But then it's like, ultimately, they said they wanted to work on that thing. They said they're ready to work on that thing. They said that's the emotions that they have. There's a lot of like having to kind of like be a bit assertive, but very gently assertive, and then kind of like being very present and being very aware. And then, when somebody feels like they're being called out, they might not schedule sessions anymore, or they might feel like weird about, how you're approaching them. And especially if you've been working together for like a lengthy amount of time, and then all of a sudden, you're calling them out on stuff. It just doesn't feel normal. A lot of people have been in therapy for so many years sometimes with the people I work with that, they're not used to people actively taking a role in their treatment and actually working on the emotional issues. So they might take it wrong and be like, my other therapists weren't doing this. So there is kind of this process too of like, the way I would get around that would be like, it's just tiring, to just be like, okay, like getting a lot of permission. There's a lot of like I'm not saying that like there's not consent involved in things, but there's a lot of like, okay, can I get your permission to interrupt you on this, to bring up this thing, and then now we'll talk about how do you feel about the fact that I brought that up, and hopefully they can articulate that and you can kind of work through that little bit of the process quickly enough to get back to talking about the anger. And then, again, and another defense is going to come up. They're going to start talking about the anger, and then that's going to, another common defense is like the memory. They'll be talking about a story that they think is related to the anger, and they'll be talking directly about like, how do you feel right now? How explain the anger, and they'll just be talking about like, like even if you ask them like physically, how does the anger feel? Like how can you tell that you're angry versus not angry? That's a simple kind of thing I like to ask people, like what's the difference between the anger, physically versus when you're not feeling that anger or when you're not tuned into that anger? Like how would you know? What does your body do? What changes? And they might say, something as simple as like, yeah, like my facial features are tense, and my, I kind of clench my fists, and like my, and the other day I was angry and I was driving on the freeway and I had my hands like clenched around the steering wheel, and I couldn't think about, I couldn't remember, I couldn't realize like why my hands were hurting so badly, why I was having all this like wrist and forearm pain, and wait, what was I talking about again? That right there, that whole like forgetting like where you were in the story, forgetting what you were talking about, like that's definitely another type of defense that's like it's almost like a trauma response too. It's like you're overwhelmed by talking about this experience that's directly related to the emotion. And so, I mean, that's just what the mind does. It tries to protect us from things. And then sometimes you might be kind of ready to work on something, but then there's other parts of your mind and body that kind of aren't really, working with you to work on it. And so these defenses come up, and it's like, wait, let's just cloud your memory so that you just don't even remember, because you were so in the re-experiencing and of that anger that you experienced while you were driving, and that's an example you were giving, and then you just kind of forgot, and it's like that's how you can kind of tell where the client is at with things, is like how the defenses are coming up and how often they're coming up, and then gently kind of like pointing them out or getting permission to point them out, or figuring out through supervision if you should be pointing them out. It's a really intensive type of therapy, but also I do think it's very useful, because then people start noticing patterns about themselves. You start noticing patterns about the clients, and I do think it helps like in a very short term portion of the session. I've noticed most clients get super overwhelmed by like a 45 to 50 minutes full-on session of like talking about defense mechanisms and staying with the emotion and talking about the emotion. Like that's hard for any of us, like even if you're not even having like some like massive like symptom issue or some major disruptive emotional issue going on. Like it's hard to like really talk about that more directly. Like it really does take building up a tolerance to emotions. Like that is not easy, but it can be necessary, but it's not easy to do, and a lot of us aren't really taught how to do it, and it's just it's it can be hard. But I never like it that my clients are in like a certain like situation and like, oh gosh, now they got to deal with this when things were going so well. It's like you just got a new job and you were happy and you're starting new work, and now you got to start thinking about like your stupid abusive people in your life that you have to like go back and have to like deal with, and like are they going to manipulate the situation and all this kind of stuff. Like I don't wish that on anybody, but also it's kind of like, I'd rather work with people on that level than like texting them like, hey, you're right, do you have any appointments this month? Did you go into any appointments this month? What appointments do you have this month? Do you need transportation? How are the appointments? Are you getting the meds? Like, do you have the medical equipment? Like, and then a lot of times, even if they don't have all the stuff that they need, there aren't really resources for us to help them with it. It's like, I have clients who, for example, have changed from one, insurance branch to another, and then they need like something, say with like a CPAP machine, and they need like a portable way to kind of like keep like a breathing device or something while they can like walk around, but then they can't really get that device because now the new insurance branch doesn't cover the device, and then maybe the other device was recalled and now they don't have the part anymore because it's old, and like it's like all this kind of stuff that you're just like, I mean, it's cool to help people when it actually works, but it's like eventually like we just get into a cycle where it's like the insurance says no. I have to call the doctor again and tell them to write another, authorization and appeal the previous authorizations. Did they do it? The insurance didn't get the paperwork. Let's call back the doctor. The doctor said they sent it already. The insurance did get it again. And now they have the paperwork, but they need more information. Contact the doctor. They said they need more information. Can you please send some proof through progress notes? They attached the progress notes. I sent it over. You contact the insurance. Did you get the authorization from the doctor with the appeal information? No, we didn't get the fax. Oh my God, I gotta call back. It's like, and then eventually they're like, oh, we see it, we read it, Medi-Cal's gonna deny this. And it's like, what the fuck, like we could go back and forth for like a month about one stupid piece of paperwork being lost here and there. And, it's just frustrating. I'm like, I don't want to do that. It's like, I don't have any power to authorize anything that these people need. All I can do is recommend. I can do the referrals, I can follow up with referrals. And it gets to a point where we have to like harass these offices, to even like, I mean, these are the offices that answer their phones and that don't have, like, voicemail boxes that are full, or that the phones just ring off the hook, or that you can contact after 12:30 p.m. Like a lot of sites, if you don't contact them within the first hour of when they're open, the callback line is so backed up and you're still trying to work throughout the day. You don't have time to be just like stopped. And it's frustrating. This job is like, it's draining in a weird way because it's easy, but it's just like, there's only so much that we can do. And then the whole purpose of my job right now is not necessarily to keep people out of the hospitals, because sometimes they definitely need to be in a hospital, but to try to keep them decreasing ER visits, because a lot of the clients we work with were referred to us because their primary method of getting support was to use the ER, and that cost the insurance a lot of money. And so they realize, on average, a lot of these people don't see their providers. They don't have connections with providers. They don't engage with different people that they need to routinely. And then the problems get more and more severe until they end up at the ER. And then that's costing the insurance a lot of money. But then the issue that we run into is, we're trying to limit their hospitalizations, but then we are limited because all we can do is call everybody and confirm things or deny things. Did it go through? Okay, I'll call back. Did it go through? No, it didn't go. They said they sent it. They have a receipt that says that the fax made it to the place. Can you please check your damn fax machine? We check the fax machine and the fax machine is broken. It's just stuff like that. It's like, I have no control over any of this. There's so many of these sites that are just so unorganized. They don't have the funding. They don't have the staff. Retention of staff is a big thing. They don't have so many things, and I'm not blaming them, but it's just like, this is such a fucked up system that, like, we can't even really do our job of trying to keep people from limiting their hospital stays because the services just don't follow through. So at the end of the day, I'm like, okay, what the hell am I doing here? It's like, we are trying to limit your people from going to the hospital. The reason why they're going to the hospital, it seems like at first they were blaming the clients, saying these people don't engage in services, therefore they're utilizing the hospital. Yes, that's true. We've connected them now to all these services, and we have all these doctors now, and we have all these different psychiatrists, psychiatric services, and therapists, and case managers, and all sorts of specialists involved in this person's care. And there's a certain point where for certain people, certain things just aren't working. If you can't breathe, if you can't, get your pain meds, and then you're relapsing on, illicit substances, instead of being involved in physical therapy and other pain management services, if you can't walk and you don't have any money to get a wheelchair, but, they're denying you the appointment that you need to be able to talk to the doctor about a wheelchair because they want you to go through another round of physical therapy that clearly didn't work the other 4 times you did it. And you need the wheelchair now so you can do a program that you're connected to that's making you do volunteer work so you can keep the temporary housing that you're in because that program is supporting you. I mean, you see, the issue is like all these little different parts that are connected to each other aren't really flowing smoothly. And so it's like all these different things that are connected, it's like, okay, something as simple as somebody not getting approved for a wheelchair can result in them being homeless on the street because they can't stay in the transitional housing, because they can't do the volunteer program, because they can't get around, because they can't walk. And so now they're homeless. And now we have to track down somebody with no phone, no address, no nothing, that we're still expected to talk to once or twice a month, and we're still expected to keep this person out of the hospital, but they're still utilizing the hospital. Why are they utilizing the hospital instead of going to appointments? Well, they can't get to appointments because they can't walk, and now they're homeless, so they're even in a worse condition, and they're more depressed and more stressed out. So now we need to try to find them housing and connect them to housing coordination, and they don't have any money yet. And, if you're trying to rely on SSI to come through, I mean, that can be like a 3-year process. It's not like they're going to get it today or tomorrow. So, I mean, there's just so many holes that I'm just like, okay, you got to patch up the damn holes so we can do our job over here. It's like we hit brick walls with almost all of our clients. There's like a wall. And then we're over here trying to like chip away at the wall, and they're like, I feel like they're just like building the fucking wall faster than we can like chip away at it. So yeah, it kind of gets to a point where we're almost like harassing other sites to like, we have to like pressure them. It's not too uncommon for me to like sit on the phone with the hospital site and just be like, I'll just sit here on the phone while you send the fax to the insurance. And then once you send it, let me know when you get the confirmation. And then you're going to have to hold while I make a 3-way call to the insurance and verify that they got it. And then I'll get all three of us on the phone and be like, they said they sent it. They confirmed to me that they sent it. Can you please check the fax? And then, did you get it? And usually they'll say yes by that point, because it's like, now we're all on the phone. But then, the referral might lapse because nobody follows up with it in the first place. And it's like, oh my God, like now we got to do this again. I've got like 38 clients right now. It's like, how much am I really doing? It's like at a certain point we just hit all these walls, and there's nothing I can do. There's nothing the doctors can do because the insurance is blocking all this ability to get all the extra stuff that the people need. So whereas in the beginning they were blaming the client for not being engaged, and now it always comes back Now, once they're fully engaged, once they're fully connected, now the insurance is the problem in everybody's scenario. That's usually what it comes down to, is the insurance doesn't approve enough of services, of medical equipment, of different types of specialists, of different types of support referrals, of homelessness resources. The insurance doesn't cover that kind of stuff, enough of that kind of stuff for people to not have to utilize the hospitals and ERs. So I don't really know what to do with that. Because we do hit like brick walls, and then it's like, okay, well, now this person's stuck in the house, and they're breathing in the house, but they can't get to their appointments, because it's not covered by insurance. Like, if the insurance isn't covering anything and approving the appeals and all this kind of stuff, then like we kind of are at a standstill. And that happens too often, where it's like the insurance just isn't doing it. So I spend a lot of my workday kind of racking my brain about how to resolve that issue. It's like, I communicate this, like, we have a very close relationship with these insurance branches. Like, I've got a reputation with them because of some of the complex client cases that I've had to deal with, that I was like consulting with them, and I was just like, look, like the reason I'm calling you is because my boss can't do anything, because I can't do anything, because the client can't do anything, and none of the referrals are working. The last place that I can contact is the insurance. So I'm going to keep calling the insurance and calling and calling and calling. It's like, what else am I supposed to do? Like, I need them to approve the stuff. They need to pay for it, because these people don't have any money. Like I said, they can't work, and if they can work, they're not making enough money to be like paying for like electric wheelchairs and paying for like breathing machines and paying for a car so they can get to and from their job, and like paying for all this stuff. Like, they're limited on income. That's how they qualify for Medi-Cal in the first place. Because they don't have a certain amount of income, where they can even afford to pay for insurance out of pocket. So they don't have any money. And insurance is not really that expensive. Like, it's a little expensive to pay out of pocket, but it's not that expensive. Really, it's not. Like, if you have enough income to support yourself, you're usually able to handle that deduction for your health care, usually. Ideally, hopefully, for most people. But, once they reach the rate where they're getting, employee benefits, you're usually not going to qualify for Medi-Cal anyways, unfortunately. If you're at a site that's giving you benefits, usually you're making too much money if your work site gives you benefits. So I don't know. I veered off, because I was done talking about what I was trying to say with ISTDP, but I'm still like racking my brain about this employment stuff. I'm just like, it's kind of hard to leave a job that I believe in, but the system doesn't work. I don't really like being part of a broken system, and it's kind of hard to have that rapport with our clients when it's like we are kind of like their last line of defense. They call us because other stuff isn't working, and if we are being blocked from helping them by the insurance, like, we don't have money. Our program doesn't have money to be like buying wheelchairs and buying all sorts of stuff. We are lucky that we have at least sometimes a single one lifetime referral that we can do for certain things, like for people trying to get housed if they get like evicted or kicked out, or like some tenancy kind of issue with their property or whatever. We can do a one-time referral to get them money to pay for first month and deposit to get into a new place. But that's assuming they can figure out how to pay their rent for the rest of their life. They can never use us again for that specific referral. So it's not really a solution. It's just like a quick kind of like, it keeps you off the street if you're getting evicted, but if you don't have money in the first place to pay for this new rate, which most of the new rates or more than anybody can afford, it's like, I don't know. I don't think there's really a solution. I mean, we're lucky that our clients are in San Diego, meaning that they can move to Mexico, which is cheaper and way more affordable. And that really, I think, honestly saves a lot of lives of people feeling hopeless. You know, at least they don't have to be on the street and in these programs that might take too long to help them, and exposed to all sorts of stressors. Like, a lot of our clients have I don't think I have one client in a situation that is in their situation of physical and mental health problems to a point where they should get disability, but not all of them have it or qualify yet. They're still in the process, but they all pretty much, in my opinion, should get disability because they can't work enough to support themselves, and because of their symptoms. And I don't think I have one client that doesn't have a trauma background. So that's saying something. You know, I've said that before. You know, I don't think I have one client that doesn't have a trauma background, even if they weren't formally diagnosed with PTSD, or if they're not actively working on their PTSD. I don't think I've ever had one client that didn't have a history of trauma, whether it was very recent trauma or trauma from childhood. Usually the trauma is related to poverty-related issues too. Like, a lot of it's generational kind of poverty, where the people's parents weren't really, you know, super able to support the family, and, you know, they weren't maybe pushing education, you know, or the clients, you know, were not formally diagnosed with some sort of with a condition that they had that led to inability to perform well in school, if it might have been an intellectual disability. But I think a lot of it really was mental health, which presents itself in a lot of intellectual ways too. But some of them do have, you know, non-formally diagnosed, you know, issues in school. Like, when you start talking to them about how'd you do in this class, how'd you do in that class, you know, that translates into, you know, people not being able to graduate high school or get a diploma, or, you know, even have an interest in going to college, or be able to place out of, you know, into the college courses that you eventually need to transfer from a community college into a university, to be able to get a bachelor's degree. And then, at least with a bachelor's, you might be able to find something. Depending on the bachelor's, you might be able to find work where you can support yourself. It's like, a lot of them don't really have that. Not that they can't do it, it's just that they don't have that as their background of something that was available for them, or that they were able to do, or that somebody was recognizing they couldn't do. Like, and the teams of people that I work with, we are the ones who recognize, after months and months of talking to people so often, and talking to the same people, and getting to know kind of the patterns that they experienced in their past life, like in their past history, we then learn, wow, you know, there's all this stuff that went like undiagnosed, untreated, unhelped, and that's why they can't work now as adults, because they don't have the skills or the, you know, patience, or they've developed all these other emotional issues from not being able to fully function, you know, for their whole youth life, the way that society expected them to function, the way that their parents expected them to function, the way that, you know, schools expected of them, and everything. And now they can't support themselves, and then the system doesn't support them either. And, you know, I don't know. I'm going to have to think it through more, but I don't really know what kind of direct actions can take place to help some of these situations that I see firsthand, that I know are contributing to so many issues of our people. It's like, something's got to give, you know. Somebody's going to have to bend over somewhere and give a little leeway to the people who don't have any money, so that they can get better. Otherwise, this job doesn't work. These people aren't going to stay out of the hospitals. The insurance branches aren't going to stop losing money because they're the ones that don't have enough support for the clients that are connected to their services. So I don't know. That's my rant for today, but thanks for listening.